part of this is showing, some of the after effects of extravasation. And I think the main part of this is still trying to understand the magnitude of the problem. So with that being said, we'll kind of get right into it. We just did a brief survey of 8 large teaching hospitals about what nuclear medicine's processes were to vascular access, because nuclear medicine, very complex therapies, very complex medicine, but a procedure of a needle going into a vein is what ensures, a good outcome. And so the answers we got were really surprising to us. None of the large teaching hospitals we had strong policy and procedure in place. There was no annual competencies. Basically, what we ran into was a senior technologist oriented a new technologist. It was kind of a see one, do one, teach one, and they were off and running. The confidence of a lot, as evidenced by that recent letter that was shared, the confidence of a lot of these nuke med technologists in vascular access skills as patients get more challenging veins with obesity and different diseases coming into play is low, as it is in nurses across the country. Skill sets also with nurses are decreasing, not increasing. We found out that the best technologies, or actually almost any technology other than a tourniquet, was not being used, and that if there was a suspected extravasation, the concept was kind of go ask the doctor and tell us what to do. There was no kind of written out policies and procedures on the correct steps to take. Even on this memo from the Society of Nuclear Medicine, they talk about things that just show me there's not the infiltration, sometimes referred to an extravasation. Infiltration and extravasation are definitely two different things, right? Extravasation is the leakage of a vesicant fluid that can cause tissue injury or damage. That's different than an infiltration. Even in this little blurb that they put out, there's mistakes about how to treat this. And a lot of times you do not want to ice this. A lot of times it's very important to get another needle and some saline, inject the area to disperse that radioisotope. You want to evaluate these patients. You want to follow up with them. Very little of this is being done. And when I think about the magnitude of this, when there's 30 million dosages given every year, if you assume a 5% extravasation rate, that's 1.5 million bad injections. I just think that we need to learn a lot more information about the scope of this problem. So how do you prevent this? Well, good vascular access procedures are dictated by your training, by your policy and procedure, and your competency. So as evidenced by the previous slide, when those things are missing, it's hard to expect technologists to have excellent vascular access skills. You've got to know your anatomy. You've got to know what the communication of, we've already poked 5 holes in that arm, often is not communicated to the nuke med technologists. So the possibility exists that even they get a good cannulation, that there's 4 or 5 holes above that site that allow for extravasation. So there's no reporting from the floor to the nuke med tech about what previously has happened. You've got to know what your vesicants, irritants. I think it's safe to say that almost everything we're injecting here is in the vesicant category. How to mitigate that. You got to have your skills validated yearly. Just because you were signed off 2 years ago doesn't mean you're still competent. And this is a basic tenet of nursing IV practice, is that you have a yearly competency check. The fact that it doesn't exist in a lot of facilities, and the scope of that, we're not that sure, but in the hospitals we surveyed, for me as a vascular access nurse, it's obviously it's very concerning. It's more than that. It's kind of actually unbelievable to me, but that's, I guess, why we're on this call today. So when IV access goes bad, so here's just a case that we had. I don't want to read the whole slide to you, but he presented and he was told use ice elevation. We dug into the medical record a little bit and found out that the peripheral IV, there was no blood return noted from the IV, so the good IV may not have been so good. because a lot of times, unlike a chemotherapy where they must use a fresh IV and they must have blood return in order to use it, a lot of times nuclear medicine can use an existing IV. You know, as long as it's free flowing, a lot of times they will inject it. And this was the result. He was discharged, you know, from the ER visit, and their approach was to just keep an eye on it. Next case was a kind of a complicated case. This guy got injected through a site that already had a midline. I wish I could have had a miniature camera in the vasculature to see what was going on, but midlines, of course, obstruct vessels because they're blocking flow. And the vessel next to this was an 18 gauge was started. That in and of itself is problematic. And the larger your IV is, the more of the vessel it takes up and the less hemodilution you have. So you have a vessel, an arm that was already somewhat compromised by a midline presence, and you know, where this basilic and cephalic vein join was probably already clogged up by the midline. So I'm very curious to know, you know, how much of this nuclear med injection was retained inside the vessel as a result of extravasation, and how much more was retained because it was a poor choice in the presence of a different vascular access device. This patient did expire from other causes 6 weeks later,